Good morning. As Amelia said, I was asked to speak or to lead a discussion on communication between referring providers, home health, and kind of beyond. So it's kind of a mouthful up there, but communication is the gist of it. So during transitions of care, patients are at an increased risk of having complications. A lot of times they're in the hospital, they get instructions from a provider, they're still under anesthesia and expected to remember it, or they've been given kind of conflicting information sometimes. Sometimes they're in a lot of pain, they don't understand. They get home and they're like, I don't know what's going on, and they've got a lot of questions. So as home health providers, we're in a unique position to assist with some of that care coordination and communication between the referring provider, their primary care, and just to be there to answer questions in general in those transitions of care. A quick review of the literature and pulling some information from those. One site, Gerdzes et al., says effective communication during transition of care is critical to patient safety and has been shown to improve health outcomes and increase patient trust and engagement. I think that's a goal that we can all get behind, that we want to increase our patients' trust. If they're engaged in their care, they're more likely to participate and have better outcomes. Pesco et al. Found that poor communication between home health care nurses and physicians has been found to increase the probability of hospital readmission by nearly 10% in certain patient groups. That's important, only because we don't want our patients going back to the hospital. We don't want them having complications. We want the best outcomes for them. But also in this day of value-based purchasing, it can affect our reimbursement rates as well, having them go back to the hospital. So good communication is critical in helping get the best outcomes and affects our bottom line too. So in this room, if you have ever written an order to refer someone to home health, I want you to raise your hand. Keep it raised. Oh, not as many as I had expected. Okay. If you are a primary care provider, any of you? Okay. So we get referrals direct from primary care. A patient will go to their physician for their annual checkup, or they've had some issue that they're following up with. The primary care refers to us. If you are surgical, on a surgical team and have written a provider, an order, got a few, that happens with a fair amount of frequency. Usually as home health clinicians, we're aware of those referrals before the surgery, which is super awesome because then we can reach out to those patients beforehand and communicate some information if they need it. One of the companies I work for actually allows us to do a non-billable pre-op visit where I go out and I can answer questions and help them understand any questions they have before and communicate any questions they have back to the provider if needed, to the referring physician. We also get referrals directly from hospitals, typically for emergent surgical cases, medical cases, trauma. The hospitalists will refer to us and we take it from there. Referrals from skilled nursing for a rehab facility. I think you do some of that. That's a big one. We actually get quite a few from that. And I would say that actually sometimes is where we find a lot of our communication issues, not because of you, but because the primary care physician doesn't know that their patient's been in a rehab facility. And so there's a lack of communication there where we can help bridge that gap sometimes. And then referrals from specialists. Sometimes we'll get referrals from like podiatrists, wound care specialists, oncologists, variety of people, pain management specialists. So as a referring provider, so those of you who have referred before, what type of communication do you expect from your home health clinicians? If you refer, what do you expect to get back from them communication-wise? I know who the providers are because you raised your hands.
Yeah. So I like to know if there's a complication with a wound that we've sent, the home health provider out to see them, and they've noticed that something's not normal. That's really helpful.
Perfect.
Just change in status. If we send them in one state and then they go out and see them and vitals, signs have changed, or communication or cognition or something like that, I like to know about those changes so that I can jump on it quicker and
Perfect.
make sure that we're
being able to act more quickly on any complications or, okay? Anything else?
It's a little bit different than what you're describing, but it's nice if the communication that you're giving to the patients is consistent with the communication that we give to them.
Yes.
That way they gain confidence in the plan and don't get confused, because if they're totally different things, then the patients don't really know what to think.
Yeah, I think that's super important. I do see that sometimes where maybe like things like protocols, things like that will help to kind of make sure everybody's on the same page so that we're giving the same information as the referring provider. I think that's super important because it does cause confusion, and then, like you said, they're not on the same, they have a lack of confidence in the plan going forward. So Medicare does have some guidelines for us that we are required as home health practitioners to communicate with the referring provider. So minimum requirements on admit or eval, we are required to report back to the physician, the referring physician, or their primary care, depending on who's going to be signing the orders, that we've completed the admission and what our plan of care is, including our frequency and our duration, our interventions, and our goals. That admit has to be completed within 48 hours of us receiving a referral. So if you send us a referral, we should be out there within 48 hours to see the patient. On admit, we're required to do a medication review, and if we find any discrepancies in medications or conflicts, we run it through a thing to see if there's any conflicts with medications. We are required, again, to reach out to the physician and let them know that we found that. The interesting part of communication here is that in addition to just letting the physician know, we also have to document in our record that we received some sort of resolution and communication back from the referring physician within 24 hours. Yes?
Do you guys follow these same guidelines for commercial insurances as the Medicare?
Yes.
Guidelines?
Yeah, we follow all the same ones. A lot of the softwares that we have, the EMRs, are built in for this, and we use the same ones regardless of the insurance, but yeah. During the episode of care, if there's any change, so kind of what Steve was talking about, if there's any changes to the plan of care, and I'm going to go to the next one, or any changes in patient status, we're also required to send that to the physician. So the first one's a little bit annoying sometimes, the plan of care one. Sometimes we'll meet a goal, like a balance goal. We start out and we think the patient's only going to get to a certain point, but they progress way faster than we thought. And then we want to keep working on balance, and we have to call the physician and say, hey, can I upgrade my goal from the Berg, like 35 out of 40 or 56 to 42 out of 56, So that can be a little bit annoying, I'm sure, for people having to sign things, but it is a requirement from Medicare. Falls, missed visits, infections, or other adverse effects during the episode, or if there's any medication changes, we have to call and reach out to the physician about those. And then at discharge. So that just lets us basically let you know that we're done seeing them, and we kind of pass the torch back. So as referring providers, are you getting these types of communications from your home health clinicians? Sometimes it's probably a little overwhelming because there's probably a lot of things coming through for signature. Brad last week in his presentation talked about no longer needing to get a physician signature on after the referring provider sends in the order. The plan of care doesn't have to get a signature. It just has to be communicated back. I looked into that a little bit more because I was like, we're still sending all kinds of stuff for signature. That looks like it is specific to Part B billing. Home health is billed under Part A, so we still have to have all those signatures. So sorry about that. So before we go any further, let's play a game. I only did 3 scenarios. I should have done 4, one for each row. But we're going to play a little game. When you were children, you probably did this, where you whisper in somebody's ear and you see how the message changes as it goes down the line. So we're going to play the telephone game. Okay, we're going to stop right there. So you get to report on what was said. So tell us what you heard.
I heard a cardiologist reports on a COPD patient.
Okay, what does the original one say?
The cardiologist carefully coordinates continuous cardiac care for the confused chronic COPD patient.
Oh. Okay, a little more complex what we started with, but we got some concise stuff. Okay. That one was easiest. Okay, what about this one here?
So don't shoot the messenger. Grandma joined a biker's gang called the Opossums.
Okay, read this one.
That's pretty good.
Okay, read what it says, so we can hear the difference.
Grandma accidentally joined a biker game called the Iron Possums after mistaking their taco night meeting at the VFW Hall for her weekly knitting club.
Okay, so we got about half of the information there, right? All right, and who you have? Okay, let's hear what this one says.
It was a guy is on the computer looking at the screen about meatloaf.
And what did we start with? This one was the most complex.
While trying to update his 2013 laptop using a YouTube tutorial from a guy named TechBro42, Kevin accidentally hacked into a retired Danish weather satellite and changed the 5-day forecast to spaghetti with a 40% chance of meatballs.
Okay, so we obviously from beginning to end the message changed because we had lots of people hearing different things. Sometimes like this one, we got about half the correct information. That one we got the gist of it. This one was pretty much just completely changed. So I sometimes feel like in home health when we're communicating with providers, we lose some of that important information. What we tell one person doesn't necessarily get transmitted the way we wanted it to. We go through multiple people to get to where we need to be, and then it comes back to us. So there's a lack of, or sometimes a loss of the integrity of the message that was sent. So we're going to take a look at a few case studies just to examine ways we can improve in our communication between our referring providers and home health providers. So I've got a bunch of them here. I don't think we'll get to them all, but
I got a quick question.
yes.
Why do you think, because we talked about Medicare A, Medicare B, why do you think these requirements exist for home health versus outpatient?
My best guess to that, and we talked about this a little bit last week, is when we send in our plan of care, our 485 is what it is called, we are including not only physical therapy disciplines or occupational therapy, we include everybody that's going to be seeing that patient. So physical therapy, occupational therapy, aid services, speech therapy, and nursing services. So it's not like in Utah, we're a direct access state. We can see patients without a referral as physical therapists, but that's not the case for all of those disciplines. And so I think it's a way for Medicare to help kind of keep us all under the umbrella of one person that's writing, signing orders. So,
Just a quick thing on your, you playing this game reminds me of the misinformation that our patients hear from hospitals and disciplines and things like that. So if as clinicians we can't even get the message through 7 people, you can imagine how that miscommunication is from the patients coming from the floor, going to a SNF, going back to home, and those clinicians that they're going through, and all of the information. Typically, if I don't know how many providers have seen the packet that nurses that the patients get coming from the hospital, the discharge packet, but it's about, sometimes it can be up to like 30 pages long that they get of just information. And then that has to be, they're expected to read through all that, and they've got the communication from the nurses and the doctors and everything like that. So it's a lot of information that goes oftentimes in one ear, out the other. Exactly. And so as we are, seeing patients and stuff like that, I do think having good, concise communication to your patients so that they understand realistic expectations and they understand what we're trying to get at, so that it's not all this fluff everywhere. And so it's very difficult for patients to, I work in SNFs, but I also work as a home health provider. So I work 2 different fields, and seeing even just that one breakdown in communication from the hospital to the SNF, there's a lot. Like a skilled nursing facility. So there's a lot of breakdown there where I spent a lot of time just communicating what was already communicated in the hospital, but the patients forgot.
Yeah.
And then seeing that going from one more level from the skilled nursing facility to home health, there's a lot of misinformation there that you have to go over and over.
Yep.
So to make sure that the patients get it. So there's a lot of stuff. Just the good communication is really important. You can see how it was here for us.
Yeah.
As well.
And I think that's super important. Patient with the communication with the patients as well as with other providers is, I mean, that's how we find the right thing for the patient, right? We help them understand what needs to happen. So, okay, so on these case studies, we're going to just look at what communication would you expect in this scenario and what really happened. I'll tell you what really happened, and then how can we improve. So I want to just look at those with each one. So first case, 71-year-old male, status post L4-5 laminectomy. It was a same-day surgery, went home, was admitted same day by home health and by physical therapy. 3 days later, went back, and the patient was really nauseated. He's vomiting. He's unable to keep down any fluids. He's feeling really dehydrated, weak. What would you expect from us as referring providers from their home health team? What kind of communication would you want?
Medications. What medications they're on?
Okay, he is not on any antiemetic. So he's on the typical like oxy, pain meds management stuff, but nothing for the nausea. Anything else you'd expect?
Probably just that.
Yeah.
Doing some surgery that's not normal.
Yep. So in this case, our home health nurse called the referring provider, said, he's got nausea, he's not on any anti-nausea medications, and the provider wrote a script, sent it into the pharmacy. The patient was able to get it that same day. And then about 7 days, it seemed okay for the first few days. 7 days post-surgery, went back again, and they had written for Zofran. Went back, patient again is vomiting, nauseated, can't keep anything down. So at this point, what would you expect?
Is he having bowel movements?
Yes, he was.
Is he dizzy at all?
A little bit, mostly probably from being dehydrated.
Is he eating anything with his pain medication?
Yes. Oh, he's trying, but he's vomiting enough. Having a difficult time there.
Is he on blood pressure medication?
He was actually. So in this case, we called back, reported to the physician that the patient's having these issues. Still, the Zofran isn't working. They wrote a script for another anti-nausea medication, I can't remember which one, and took care of the problem. So the patient was fine. The biggest issue here was we were trying to keep him out of the hospital because he kept saying, I'm going to the hospital because I need fluids. And we're like, yes, you need fluids, keep drinking. Try to keep it down. So there was a little bit of a delay in his symptoms, but in this case, I think we did pretty well. The surgeon was able to respond pretty quickly and get those new medications out as we were seeing the symptoms. So. This one, 87-year-old female admitted to home health by her primary care physician after a regular visit. They had actually just established care, so the primary care physician hadn't been seeing them for like 10 years or anything, new patient for them. The patient's main complaint was for it was dizziness. And they're admitted, follow-up treatment. Her blood pressure was 100/62 when she was seated, but when she stood up, her blood pressure is dropping to 75/48. When she stands, she is taking lisinopril, metoprolol, can't say that word, spironolactone, and torsemide. So as a referring provider, what kind of communication would you like from your home health team?
Still taking her blood pressure meds with the blood pressure low?
She is, because
she was told to.
She was told to, and she actually lives in an assisted living facility.
So
they're giving it to her regardless.
Don't do that.
Stop doing that.
Stop that.
Stop that. Yeah.
Maybe skip it.
Did they diagnose orthostatic hypertension?
No, that is not a diagnosis she has, no.
She
But
does not have a diagnosis of orthostatic hypertension.
I think she does.
But I mean, like, she does, but she doesn't. It is not in her charts. So in this case, called the referring provider and just said, she's having these symptoms, she's on these medications, and basically I said, you may want to take a look at the medications. What really happened was I called and left that message. 4 days later, I went back to the patient, and she still hadn't heard back from her primary care. So this happens with a fair amount of frequency, unfortunately. We don't get that. My question is, as referring providers, if we don't get a response back from you, how annoying is it for us to keep calling? I mean, like, how often would you expect us to follow up, I guess, if we don't get response from our initial attempt?
We try to answer our messages within 1 day, so if you
So if you
haven't
heard
heard
back.
back in a day, maybe,
Okay.
yeah.
Perfect.
Or if it's over the weekend, obviously, you could
Yeah.
reach out to our phones personally
Okay.
in those situations.
That's good information, because sometimes you're like, well, we don't want to bug the doctor, right? We know they're busy, but at the same time, we need to take care of the patient.
It's all about patient safety.
Mhm.
So if you haven't heard from us,
Within
keep bugging. I'm okay with them bugging me because they're high risk for multiple things.
yeah. So I'm going to actually skip through all of these because we've only got like 3 minutes left and look at how can we improve. So these are suggestions taken from me just talking with other home health practitioners and also from some things I read in the literature. So coordination of care prior to the admit is awesome. That's really helpful when we have surgical cases to get those referrals before we admit. Direct contact to the referring provider. This was the number one thing that the home health nurses I talked to wanted, was having direct contact. When we have to go through your office, we lose time, and sometimes that message breaks down. So there are certain providers who, are really free with giving out their cell phone number. Others are not as free about that, but that's the number one request of home health nurses in this situation. I think educating staff on items that are emergent. So if we do call into the office, sometimes things are a little more critical than others. If there's a patient who has an infection and it needs to be treated pretty quickly, that's something that needs to be communicated more quickly maybe than, oh, they had a fall, nothing happened. There are no consequences of it, no injury. Providing access to the hospital records, accountability, willingness to sign orders, checklists and structured protocols was one of the things in the literature that showed that facilitated better communication. The ability to send photos is really nice because it allows us what we're seeing in the home. If there's a problem, we can send it directly to you. This probably is a whole nother discussion, but texting, is it HIPAA compliant or not? From my personal cell phone to your personal cell phone, probably isn't. There are ways to just designate patients by the last 3 digits or last 3 letters of their name that might be, but including any other information is probably not HIPAA compliant. So I decided on eliminating the time lapse. So it took a while for that message to get down, right? And sometimes we call the office and it takes 3 or 4 days to get the message back. Anybody have suggestions on how we can work on that? That seems to be one of the biggest issues that we run into. Thoughts? I mean, it sounds like you already have a kind of procedures in place to try and respond within a day. So.
I would just say individual relationships with people. I mean, if you think about what we're doing here, if I know Lindsay really well, it's super easy for me to contact her.
Yeah.
I can ask her, hey, what's your preferred line of contact? And if you have a regular provider that you refer to or they refer to you, have that in-person relationship. I know that's not likely for all home health therapists, but it really helps.
That does. I agree with that, because if you have communication and you know how they like to be contacted, the best method, then it's easier to communicate. And then the last thing, really quick, communication with outpatient therapists. What type of communication as outpatient therapists would you like to see from home health therapists? Honestly, I rarely call an outpatient therapist to say, here comes a patient. I've done it like probably twice. And once was because I was helping him schedule because he only spoke Spanish and I needed to help him figure that out. Any thoughts on that?
Two thoughts. We always get hung up on if they've been discharged from home health. Because if they're not discharged and they start outpatient.
Then that's a big problem, billing wise.
So that's one that I think always clogs it up. But the other thing is, when we've had communication, it's always in circumstances where like there are specific goals or specific needs, or we're reaching out saying, hey, this patient may have Parkinson's, who do you have someone that works with this? Or I think there's specific needs that we can help figure out is what's helped us.
Okay. Do you have suggestions for helping communicate that we have discharged the patient so that you can take the reins?
Yeah, so it's always a letter or something that we if we have that, we can submit that.
Okay.
And that helps out. But I don't know a better process, because that's very frustrating for the patient. Because they're like, I finish home health Friday, want to start outpatient and ready to go. We're like, okay, we've had many experiences where we started and they denied it for the first week.
Interesting. So I've actually had a few requests from outpatient clinics asking for some sort of letter, and I'm like, I've never sent a letter. Do you have specific requirements in that letter that you need, or is it just like the home health provider can say, I discharge this patient, like a handwritten, like what?
Look at what it is.
Okay.
I think it has to, I'll have to check.
I think it has to be a discharge summary when you put which them has.
Oh, the discharge summary, that would make sense.
Because you have achieved and you have getting home care to this level, and now you're going to outpatient therapy.
Okay.
And then you don't receive a denial.
All right. So that would make sense, the discharge summary. Okay. Okay. Well, we're out of time, so I'll go ahead and finish, but thanks for talking and communicating with us today.